So we are going to look obviously at flexion. So we are going to go obviously active, passive, with overpressure and resistance. So bend your knee up towards your chest for me, sir. Brilliant. See, what I normally do, right, is I don't then do them all separately, but it's whether you can remember to do that. So I go lift your leg up towards your chest as much as you can. Fabulous. Relax. Can I do that? Yeah. Brilliant. You relax. Brilliant. Overpressure. And then I want you to pull up towards your chest. So I don't then go back and do them separately. But people forget that because obviously it's new to you. So learning how you want to do it is the right way to do it. So we've done flexion. We've done active flexion. We're going to do internal rotation. Now remember that his leg going out, his foot going out is internal. And his foot coming in is external. It's the reverse. Okay? So we do that and that. So then what I want to do is just take this leg to there for me, put my hand on his pelvis because I want to know whether he's cheating or not, because when you take your leg too far out, you're going to move your pelvis to get a bit more movement. So I want to know what his movement is. So I want you to take your leg out to the side for me. Can you do that?
Left leg.
This leg out to the side? This leg? You've got two. So there, when he gets to there, he starts to do this, and I know that that's his range of motion, yeah? So just tell me where he's at. And then I want him to go across his body now, the other way. Fabulous. And then I'm going to repeat that passively. So I'm going to take him, and relax. And I'm going to take him, and then I'm going to come back to where I didn't do before. You feel my hand? Keep your leg there for me. You feel my hand here? Yeah. Don't let me move you. Don't let me move you. Don't let me move you. Brilliant. Don't let me move you. Don't let me move you. Brilliant. Yeah? Feel my hand here? Don't let me move you. Don't let me. That's pretty good. Okay. Don't let me move you. Good. Yeah, so I'm just moving from one to the other, mirroring what I've done before. So, palpation, we're clearly not going to look at the pubis or the anterior joint line. So the anterior joint line is here in your iliac fossa. Okay, so we're going to look at the anterior superior spine. Big things here. Then you're going to say, I would palpate down to the pelvis and up the iliac crest or the anterior joint line, which are these areas here. And then obviously I'm going to move this gent onto his side. So do you want to face that way for me? So we are going to palpate. So you've got tensor fasciae lata here at the front. I'm going to palpate around. I come around the hip onto the greater trochanter. The greater trochanter, you kind of almost drop off it, and then you're into the kind of glutes and around the glutes. What else does it say? It's the ITB, yeah, iliotibial, tensor fasciae lata, iliotibial band, and the glute tendon. So to cover that again, your tensor fasciae lata is here at the front. So imagine your glutes, imagine a Y. So you've got your tensor fasciae lata, your glutes like this, and your ITB going down. And when they pull on each other, that tightens, okay? So tensor fasciae lata, gluteal tendons at the back, and then at the center you have the greater trochanter with the ITB down here. Good. Does that make sense? Yeah? No, yeah? Good. Onto your tongue for me. And then we come on to the glutes. And of course, you know, we're going to palpate. So glute med is here, but we're not really going to palpate the max and the piriformis. So the piriformis lies in this plane, the glute max here. So we can palpate glute med, but then we describe palpating glute max with piriformis running underneath it, deep to it. You can't palpate it, you can't feel it. You can be over it, you're not directly feeling it because the glutes are so big and thick that you'll just never get to it. Cool. Any questions so far? Cool with that? Welcome back, sir. Okay, so we talked about this, didn't we? So remember to set up the pelvis. So if you grab under the malleoli, you're kind of standardising it. And then what you're doing is you're putting your malleoli to the joint line of your knee. So bend your knee for me. You see, I can't really see very well. He would be in a set of shorts or something, or his boxers if I was doing it in the clinic. Then this one, lift bump, right up, drop down, straighten this leg, straighten this leg, and then anterior iliac spine, whoops, anterior iliac spine to the base of the malleoli, yeah? Then either umbilicus to xiphisternum, doesn't matter which one. Umbilicus, if you've got somebody who's big and fat, you probably don't want to do that, you're probably looking for xiphisternum, and you're going to come down. So anything above here is to do with scoliosis, a twisted pelvis, a rotation, a soft tissue, etc. Anything from here is truly a difference in leg length. Okay. Right, special tests. So, for DARE test, flexion, adduction, internal rotation. An articular test for the joint, okay? We're looking at articulate stuff here. Okay, so we're coming up. So it would be positive in something like femoral acetabular impingement, FAI, you would have a positive for DARE test. Coming up, and internal rotation. Right, so. Great. Favours, flexion, abduction, external rotation. Again, related to things like piriformis, can relate to the joint and restriction through the joint. Yeah? Cool. McCarthy's. Now, some discussion about McCarthy's, but in essence, so I think, was someone saying that you internal and external rotate all the way through the range? Is that what the discussion we're having? Can't remember, we had a discussion about this.
On the physio tutors, they do it one internal, one external.
So they do like this?
No,
so
well,
like this?
They do all with one internal and all with one external.
What, so like this?
No, they don't like do back and forth. They'll just internally rotate it and then take it out.
Like that.
Yeah,
and
like
then
that.
turn down the external like that.
Okay, alright. So if you want to do it like that, I tend to come in and out as I move, but if, again, it's just people do it in a different way. Do you want to do it like physio tutors where it's all the way in, you remember it, and all the way out, doesn't matter. But you will see clinicians coming in and out of it, almost like a bit like a Matt Murray's test, where you're trying to provocate the labrum and the soft tissues of the hip. Active straight leg raise. We know that after surgery, so anybody had a hip replacement, they'll be told not to raise the leg straight up. A lot of pressure goes through the joint as you lift your leg, and if you've got a brand new joint. So what we want you to do is to lift your leg straight up for me and just hold it there. Now, if you look at the test, that's the active straight leg raise test. But again, when I do it, come on, I put a little bit of pressure on it. Again, you don't need to do that. Just active straight leg raise is lift it and hold it. You're looking for pain across the front of the joint, in the joints. Okay, so nearly there. Come and sit your bum on the end for me. So, Thomas test. Keep going. Brilliant. If you grab your left leg, take it towards your chest, and lay backwards. So, shuffle your bum if you can towards me. Brilliant. So, you'll see people doing that, tend to get people to put your hands under the knee, because you don't really, they're older, so put your hands under your knee, that's it, then you don't compress your knee. You tend to, when you're testing people like this, it tends to be an older patient, you want to rag the knee. So when I do it, again, just relax with everybody, I just come here like that, and then I pretty much control what they're doing. And so what I want you to now is lay your head back, and make sure this back is flat. So look at the angle now arch your back, You see the difference in his leg angle? So you need to standardise it by flattening the back. Get rid of the lordosis, because that gives you more range. Two things I'm looking at. This angle. Okay, so this angle, if this angle here was like that, then we're looking at iliopsoas coming from the spine being restricted, okay, or relatively restricted. But remember, it's a comparison to the other side, and some people are naturally really tight. So the first thing is this here. When we look at the lower limb, in essence, it's the second part of the test. So we look at the lower limb and we find that the knee's really flexed. It means I've got lots of length through this, which is rectus femoris, because it joins two joints. It goes over two joints, it goes over your hip and your knee. So if it's here like this, so if it was like this, iliopsoas would be tight and rectus femoris isn't. If it was like this, straight this lower leg, then iliopsoas is okay, drop a tiny bit, So iliopsoas is the correct length, but rectus femoris is tight because he can't bend his knee. He doesn't have enough length from the front of his leg. Does that make sense to everyone? Are you sure? Anybody not understand that? We're looking at this angle here, which relates to iliopsoas coming off the spine. This angle here relates to rectus femoris that passes two joints. It passes over the hip and over the knee. Yeah.
So what would be a positive test?
For what?
What was it?
For what?
For this?
So for what? For what part of the test?
Wait, what's positive now?
Okay, just I thought I'd explain that. So if we're talking, there's two components we're looking at. Okay, we're looking at what's influencing the hip itself. Okay, so iliopsoas comes off the front of the spine and comes down to the lesser tuberosity of the hip. Okay, so if iliopsoas is really tight, it'll be like this, and this angle won't be very flat because it's not very long here. It's tight, restricted here. If it's here, it's about normal length. But when we look at the lower leg, we're talking about the rectus femoris muscle here, which goes to the hip but also goes below the knee. So if this is tight, you find that this angle is like that because this muscle's tight. So in this case, iliopsoas is the right length, but rectus femoris is quite tight and restricted, which means he can't let his knee flop like that. Does that make sense? Yeah? Okay, sit on it. And just let it side. Yeah, so in that test you're looking, there's two components. So which part of the test is positive? The thigh attitude relates to iliopsoas coming from your spine, and the knee angle relates to rectus femoris, which is here. So if your knee angle's bent and it's flat, everything's perfect. If it's up here, it tends to be iliopsoas that's tight because the thigh's raised. If it tends to be the thigh's flat, but the knee can't bend, it's rectus femoris that's the thing that you're looking at.
The exact would be obvious. Like the Yeah. iliopsoas is tight.
Yeah, 100%. Yeah, it won't be a mixed picture. It'll be very much, very bound up. Okay, shuffle back for us then. And shuffle back this way, back towards me, back towards me. Keep coming. So, as we said, there are a couple of ways to do this, and to be honest, it's just a really shit test that I can't ever remember ever using. But, there we go. So, if you grab that bottom leg and bring it up towards you, bottom one. You're alright. 50-50. You were out last night. It's a Monday, not a Thursday. Grab your knee. Good. Okay. So here, what you're looking to do is to block this. Now you'll see people do this with straight legs. Okay, like that. So you'll see people push up into here and straight. The way we do it, tell me if anybody disagrees, is to fix here, block the hip, and then just see whether you relax me now. You relax. Relax. So what you're looking at is that this person can drop their leg down. You imagine if this was all tight, he wouldn't be able to get his leg down there as I fix it. Does that make sense? No? Yeah? Sit up. Does anybody seen that different, done in a different way? So somebody brought that up before.
Yeah, I was gonna say, I've seen it without like bringing that lower leg up.
Right, so that the leg's flat.
Yeah, it was essentially flat, and then the other leg was straight out. The top leg was straight and pulled back, rather than both being bent.
Pulled back into
As in,
extension.
Yeah. So,
If you did it like that, that'd be fine. But I think the way I've always been taught is that knee comes up and squares the pelvis off, and you don't have to manage that because it's really difficult to hold and manage. But to be fair, I don't care how you do it because it is an absolute rubbish test. And if you ever use it, and I don't know why I can't take it out, but apparently, if I were some people who first did the course, they said we should put it in. So I'd take it out tomorrow morning because I've never used it in my entire life. But there we go. Joe, have you used it?
Definitely.